Welcome to this explainer. Today, we're going to master extraocular muscle motility disorders, and we're going to do this by building a really cohesive clinical roadmap. We are definitely not focusing on rote memorization here. It's all about building true anatomical intuition and clinical reasoning. Think of this as your ultimate board review masterclass. By the end of this session, you're not just going to remember these facts, you'll actually understand the anatomy, the physiology, the pathophysiology, and exactly how to diagnose these patients right there in the clinic. But before we get totally lost in the weeds of specific eye movements, we really need to anchor ourselves with a rock-solid cognitive framework. Whenever you evaluate a motility issue, I want you to ask yourself one primary question. Is this deficit nuclear, supranuclear, internuclear, or infranuclear? Because those are our 4 levels of diagnosis. All right, let's dive right in.
So here is our roadmap for today. We're going to trace the pathways, exploring the nuclear, supranuclear, internuclear, and finally the infranuclear pathways.
Let's start with Section 1, the infranuclear journey, taking us from the fascicles out to the orbit.
Okay, we're zooming in on the infranuclear pathway first, treating each anatomical stop like a high-stakes clinical puzzle. We're tracing the cranial nerves from the brainstem fascicles all the way out to the extraocular muscles. Remember, a nerve is basically just a biological wire, and exactly where it gets pinched dictates exactly what your patient experiences. Now, looking at the slide, please do not overwhelm yourself by trying to memorize this entire table of fascicular syndromes, like Weber, Benedict, and Miller-Gubler all at once. Instead, I want you to recognize the classic board pattern here. A bundle of axons leaving a nucleus while it's still inside the brainstem is called a fascicle. Because these fascicles live in the incredibly crowded real estate of the brainstem, finding an isolated extraocular muscle abnormality here is incredibly rare. So your OKAP pearl to lock in right now is this. A brainstem fascicular lesion equals a cranial nerve palsy plus a non-ocular central nervous system finding, like contralateral hemiplegia or ataxia. You absolutely want to look for that exact combination on your exams and, of course, in your patients.
As those nerves exit the brainstem and travel through the subarachnoid space, they eventually bundle together right into the cavernous sinus. Take a look at this coronal cross-section of the cavernous sinus. Let's orient ourselves really quickly. Medially, you've got the sphenoid sinus. Right smack in the middle is the internal carotid artery, and riding right along with it is cranial nerve 6. Now shift your attention to the lateral wall. From top to bottom, you have cranial nerves 3, 4, V1, and V2. Because they are packed together so tightly in this tiny space, a classic board question will present a patient with simultaneous deficits of these very specific nerves. When you see multiple cranial neuropathies on one side, it absolutely screams cavernous sinus pathology.
Let's connect that beautiful anatomy to the physical exam. The cavernous sinus isn't just a tunnel, right? It's a vascular, venous structure. So if a mass, a fistula, or a thrombosis occurs there, it physically impedes ocular venous drainage. That backed up blood flow manifests clinically in the exact exam findings you're seeing in these images. On the left, notice those dilated arterialized conjunctival vessels. And on the right, you can see severe, beefy red chemosis just protruding from the eyelid. When you see a frozen eye accompanied by this dramatic level of congestion, you are looking directly at venous outflow obstruction, which is highly indicative of cavernous sinus disease.
All right, let's pause for a quick Socratic active recall moment. Both the cavernous sinus and the orbital apex house multiple cranial nerves, and pathology in either location can cause a completely frozen eye with multiple nerve palsies. So what exact clinical finding definitively separates them on your exam? Take a second to mentally build your differential diagnosis.
Did you get it? The crucial differentiator is the optic nerve. Look at the anatomical diagram here. Right in the center of the orbital apex, passing right through the annulus of Zinn, is the optic nerve. Therefore, an orbital apex lesion will almost always involve decreased vision, an afferent pupillary defect, or visual field loss. In sharp contrast, the optic nerve remains completely untouched by pure cavernous sinus or superior orbital fissure pathology. Please do not confuse the two. Decreased vision plus ophthalmoplegia means orbital apex until proven otherwise.
Moving right along to Section 2, the CN3 palsy emergency.
Let's move backwards slightly into the subarachnoid space, where the nerve is traveling between the brainstem and the cavernous sinus. We've arrived at the climax of our anatomical journey and honestly one of the most critical, life-threatening presentations you are going to face on call. This is your absolute highest yield clinical pearl. A third nerve palsy classically gives you a down-and-out eye with a droopy eyelid, but you must look at the pupil immediately. Why? Because the clinical status of the pupil literally dictates your management.
If the pupil is dilated and non-reactive, you must assume fatal compression by a posterior communicating artery aneurysm, or PCOM aneurysm. This is a massive neurosurgical emergency, and you order emergent vascular imaging right away. However, if the pupil is completely normal and spared, it typically points to a microvascular ischemic event, often from something like diabetes or hypertension.
But why is this true? We don't just memorize arbitrary rules here. We need to understand the physiologic why. And this brilliantly illustrates the topography of cranial nerve 3. Listen closely to this. The preganglionic parasympathetic fibers, the ones that actually constrict the pupil, they run superficially, right on the outermost edge of the nerve. The blood supply to the inner core of the nerve comes from the deep vasa nervorum. So an external compression, like a ballooning aneurysm, crushes those superficial parasympathetic fibers first. That leaves the sympathetic dilatory tone totally unopposed, resulting in a blown pupil. Conversely, microvascular ischemia affects the deep core vessels first, completely sparing the superficial pupillary fibers. That mental model is exactly how you're going to nail this concept forever.
Section 3 now, the internuclear pathway and the MLF.
Let's pan back out to our intranuclear framework, shifting away from the peripheral nerves and back into the brainstem. The absolute crucial point here is understanding the normal physiology. When you want to look to the left, your left CN6 nucleus fires the left lateral rectus to abduct the eye. Simultaneously, it sends a signal right across the midline and up the MLF to the right CN3 medial rectus subnucleus, telling the right eye to adduct. They have to move together. Think of the MLF as a high-speed communication crosstalk cable bridging the two sides of your brainstem. If the MLF is damaged or bagged, that crosstalk signal intended for the contralateral medial rectus just gets cut in transit. The lateral rectus fires normally, but the fellow eye totally fails to adduct. This disconnect is the exact definition of an intranuclear ophthalmoplegia, or INO.
Now, for your board preps and everyday clinical practice, you need to lock in this age-based differential trap. If you see an INO in a teenager or young adult, you should heavily suspect a demyelinating disease like multiple sclerosis. If you see it in a 75-year-old, it is most likely an ischemic stroke. And always remember the great mimic, myasthenia gravis. This deserves significant weight on your exams. Because myasthenia acts at the neuromuscular junction, it can mimic absolutely any pupil-sparing motility disorder, including an INO. Keep it on every single differential.
Finally, Section 4, Supranuclear Fixation Systems.
We're completing our initial roadmap with the supranuclear pathway. This pathway represents the overarching cortical and cerebellar command centers that dictate exactly how our eyes maintain or acquire visual targets. Think of these as the incredibly complex software algorithms controlling your camera lenses. In primates, our vision is built to detect objects and scrutinize them. To pull this off, we have 6 distinct systems. Notice the difference in triggers here. The vestibulo-ocular and optokinetic systems are driven by the environment to stabilize an image during movement. In contrast, smooth pursuit and saccades are voluntary movements initiated by the patient to acquire a target. While their mechanical triggers differ widely, they all share one unified critical purpose. Their job is to perfectly redirect and lock both foveas onto an object of interest and keep them there without the photoreceptors fatiguing. A lesion up here doesn't just cause a single muscle palsy. It disrupts coordinated gaze entirely.
As we wrap up this explainer, I want to leave you with a rapid-fire clinical scenario to test your absolute mastery of today's most critical, life-saving distinction. Imagine a 45-year-old patient is sitting in your chair with a sudden, painful, down-and-out eye, a droopy lid, and a fully blown, completely unreactive pupil. What is the exact vascular structure involved, and what is your immediate next step? Have you got it? Remember, our topographical model, the superficial parasympathetics are being actively crushed. You are dealing with a compressive posterior communicating artery aneurysm, and you must send that patient for emergent neurovascular imaging right this second. That is exactly how you use deep structural knowledge to actually save a life. Keep reviewing these frameworks, trust your anatomical reasoning, and I will see you in the next explainer.